be another standing room only crowd for the McSilver Institute Spring Lecture Series. And I want to say to students, faculty, and friends, colleagues, welcome to the Silver School of Social Work. And today's panel, as has become a tradition of the McSilver Institute, is going to integrate the scholarship, practice, policy, and service that the McSilver Institute stands for. So with no further ado, Mary, you're introducing Michelle? Wonderful.
Thank you, Nadia. Thank you. So my name is Mary McKay, and I direct the McSilver Institute for Poverty Policy and Research. And it is my real privilege to introduce my colleague Michelle, who then will introduce the talent that I'm positive she brought with. And so I just want to say just a word about Michelle, because I think that her work really focused on young adults, really helping service providers do the best by young adults, really helping policymakers just, Michelle, we have all really funders to understand what makes good services and how are we going to do this at McSilver. I think McSilver really wants to bring really talented researchers together with the voices of young people, the voices of providers, the voices of policymakers to come up with some really important new solutions. And so I think that your work embodies that. The other thing I should tell you about Michelle is she just got tenure at NYU. Those of you that are not in kind of the academic arena, they don't just give that away. You work really hard at your scholarship, and you work really hard at trying to create new knowledge that informs what we do in care. And I think that you have taken your work, Michelle, in a really important place, in that it really also enhances the voices of people that use our services, people that deliver our services. And I'm really excited to have the people that fund our services kind of listen to what this panel has discovered. And so I'm really happy to call you our colleague, and we try to really put together panels that will make this discussion meaningful. I think you have a lot of people in the audience that probably want to ask you questions as well. So with that, I'm going to introduce Michelle Munson, and she'll introduce who else is going to talk today for us. Thank you.
Thank you very much, all of you, for being here. And while Mary, says that policymakers are in the house, and that's great news, it's also intimidating, but very exciting. And one thing that I try to do in my work regularly is think about all the different stakeholders and how my work is speaking to those different constituents, from the researcher to clients who use services, to family members, to policymakers, etc. And I hope that we do a good job doing that. I want to start out first by thanking Mary McKay and thanking the McSilver Institute for inviting us, for inviting our group, inviting colleagues to talk today specifically about young adult mental health. And I also want to thank our Dean, Dean Lindbadecka, very much for supporting research and for supporting research at our school to try and really put forward scholarship that's going to impact different constituents, including policymakers and services. And so tonight we are indeed going to focus on mental health services among young adults and facing the crisis of unmet need. And so my objectives for tonight are to do a little bit of introduction and background, and then talk about 3 studies that inform the work that I've been doing with young adults and been doing with a lot of my colleagues here tonight who have generously agreed to come out and speak about their involvement with my work. So the first study is some conceptual work I've been doing since 2007. And so I'll talk about that, and then a couple of more recent projects, kind of drilling down some of the conceptual work to a specific service, the use of psychotropic medication, and then finishing off with an intervention that we're working on developing and working on understanding ways to help young adults invest more in their health, invest more in their well-being, invest more in their engagement. I also want to make sure to thank some of our funding supports. I've been doing a lot of this work with the Ohio Department of Mental Health. Many of you know I was on the faculty at Case Western, and we've been collaborating a lot on this work since 2007. Research goes so fast. Also the New York Community Trust, our own CLAF, NYU Silver is very much a part of my work in the National Institute of Mental Health. So I feel very lucky to have also folks supporting my work and providing funding to support that work. I would also like to acknowledge and introduce my colleagues, as Mary alluded to in this work, who are going to all speak, and I'm going to say a word about them before they come up, but I just want to let you know who's here and what we have represented before I get to talking about the research. So first, at the end, we have Andrea Cole, who's a second-year doctoral student here, who's been working very closely with me on this work and developing the intervention you're going to hear about today. Next, we have David Kamnitzer, who is involved at the Institute for Community Living. He's a senior vice president there. He's a seasoned clinician. He's a real advocate, I've learned over the years, for young adults and services and programs for young adults. David's taught me many, many things, and he shares my passion for young adults. He's also a clinical associate professor here at NYU and works very hard with a number of our students, some of those who are represented in this room. Next we have Redell Creary, who's employed at the Institute for Community Living and who also played a significant role in our pilot of the intervention that I'm going to be talking about, co-facilitating Just Do You with young people who were involved in that intervention. And then we have Sylvia Tidwell, who was a participant researcher who went through our intervention and is going to share some of her experiences of being part of that in the developmental process of this intervention that we're trying to develop for young adults. And then we have Nadia Jenefsky, who's the clinical director at, let me get this right, where did I write this? I want to get this right. New York Creative Artists Incorporated.
New York Creative Arts Therapists.
New York Creative Arts Therapists Incorporated. And Nadia and I have been working together since the 90s on integrating the use of creative arts and social work to help young people and try to get creative in trying to address clinical issues by using both social work skills and also the creative arts. And so I'm very excited they're all here, and I'm quite certain they'll be much more interesting than this early part of the keynote lecture. So I want to start first with just some introduction and background. We know from a lot of epidemiological studies that young adulthood, the years of young adulthood are quite vulnerable for the onset, and there are high prevalence rates of many mental disorders. We also know that these prevalence rates are particularly high among vulnerable populations of youth and young adults. And talking about young people involved with public systems of care during childhood, many studies, we've got studies represented here from young people in the juvenile justice system, the foster care systems, those rates, those challenges, the research shows that it is higher among those subgroups. We also know that service use is high during adolescence. Folks have published studies on that, and we're beginning to have a clearer picture that service utilization decreases quite significantly during the transition to adulthood. And I suspect many of you in this room know this research. But it's pretty compelling, and we are really moving now in the direction of trying to figure out solutions and ways to address these documented problems. And just yesterday, I was watching Face the Nation, which had a whole segment on this issue, and Michael Fitzpatrick, the executive director of NAMI, reported that 60% of people with a diagnosable mental disorder on any given day do not receive treatment. So really, really high numbers, and we need to focus, his words, more on early intervention and in intervening in the younger years. Also this month, Harold Kopowitz put out an editorial just this month, really putting forward this idea that we are in a crisis, that this is a crisis. We need to have national conversations around mental health services for children and adolescents, that stigma, misinformation, and lack of access have created a public health crisis for young people. And really he pointed to silence and inaction as contributing factors that can result in another type of tragedy, which is the marginalization of young people, and young people not getting the help that they need. And so I think it's a pretty important time for vulnerable youth and young adults, and we're seeing that on many levels. And so now I'm going to show you something. And this is something that came across, I was at a meeting at the CCC, I'll probably get that acronym wrong too, the Citizens Committee for Children. And this was presented, and it really represented where I feel like this work is. We are at a particular point. This is a Chinese word. Well, let me have Lisa tell you what this chrysotunity means. Lisa Simpson, Homer's, I believe, youngest, or at least his daughter. Older daughter, thank you.
Did you know that the Chinese use the same word for crisis as they do for opportunity?
Yes, opportunity.
And if I felt like we had time, I would let the panel sing for you a song they developed around the word chrysotunity, but we'll potentially do that during the Q&A, led by Kamnitzer. But I really, really believe that we are at a turning point for young adults with mental health needs. And so some of the things that I think about and my colleagues think about with me are some shifts, at least continuing to consider shifts that have already begun, all in service to improving the lives of young adults. And I should say, I'm talking about folks between 18 and 28 who live with mental health challenges. A societal shift to continue to recognize and think about strategies to move us beyond focusing on brain chemistry, right? I think we've done a good job of that in the past few decades, and really focusing closer and more on poverty and trauma and how we can work to deal with those things together for young people. Also a systemic shift, and a lot of people who hear me talk about my work, I really have struggled with this over many, many years. The idea about transition age youth services being situated in the child system versus the adult system. And I think they're both very important, but I think we can learn some things about specific young adult programs that are situated on the adult side of the service system. And then thinking about clinical shifts around the use of what our group calls role models, recovery role models, playing a key service provider role together with clinicians in running what you'll hear about later, the Just Do You group. But generally, the use of role models to model certain knowledge, certain skills for younger adults newly engaging in the mental health system, similar to peer support. So, firstly, I want to talk about briefly about a study that began in 2007 because it really lays the foundation for the work that I'm doing. And this was a project that asked the question, what are the mental health service use experiences across the transition to young adulthood? And there was a lot of research that influenced this study, but what I was finding was that a lot of the studies that asked about factors related to service utilization were looking at either specific individual level factors, okay, so that was sort of one barrier. It might be a study of how attitudes relate to service use, or how social networks relate to service use, or how macro factors relate. But very few studies were looking at the overall picture, and there was very little qualitative data on this. And then also few studies within the body dealt with the transition to adulthood specifically. So what is this experience like when you move from adolescence to young adulthood? And that led to what I call the Ohio study, which was a mixed method study where we talked to 60 young adults. The mean age was about 21. And by design, all of the young adults in this study all of them, had used Medicaid-funded mental health services during adolescence, along with additional public systems of care. They all still were struggling with mental health challenges, but by design, some of them were currently using services in young adulthood, and some of them were not. And we wanted to understand those experiences and really sort of get an opportunity to talk with young adults at length about their transition experiences with regards to service use. And we've learned a number of things, and one of the things I'm going to share is a theoretical framework that I want to acknowledge my colleague Jim Jackard, who I don't think is here, but also has played a very integral role in moving this work forward. And it really, I think, it's a framework that emerged from our data that builds upon what the service utilization theorists have brought to bear, and also social psychological decision-making theorists have brought to bear to try and understand this question about service utilization and continued service utilization. And we found a number of critical key individual level factors were salient for young adults, and we'll get into some of those in a few minutes, things like stigma, mistrust. And we found that they were influenced by key community and social factors, relationships with significant others, relationships with parents. And so this is one piece of work that has really influenced sort of our broader thinking about the transition to adulthood and service utilization. So and I'm going to share some preliminary results from a second study that I'm engaged in that looks at a specific service and begins to try and look at that theory a little bit closer and some of the constructs in that theory specific to psychotropic medication. And this is a study that's asking the question, how do young adults make meaning of their medication use? Okay? And a colleague of mine in 2010 published a paper that influenced our study that looked at teenagers. He was looking at medication use and how using medications mattered to kids who were around 14. And in his narrative analysis and looking closely at how 14-year-olds thought about and understood their medication, they found three major areas where there was data that was meaningful around the experiences of taking psychotropic drugs. One set of data was around how young people understand their challenges. How do they understand what's wrong with them? Why do they need their medication? And then what effects does the medication have for them? And how does it matter in their life? And then also a set of data on the future, the hopes, the more long-term expectancies of what medication might do for them. And we were excited about the study, and we wanted to think about it with respect to older kids, to young adults. And so we're looking within that larger data set that I showed you, the theoretical model, specifically within the cases in depth using narrative analysis to try and understand among those taking medication who talked quite a bit about their experiences with medications. We are trying to understand about their young adult psychiatric medication narratives and as they relate to decision making and how the data relate to decision making. So again, this is narrative analysis. And it's work that I'm doing with a colleague at the University of Houston, Sarah Narendorf. And again, we're looking at particular issues that emerge around service utilization of psychiatric medication or psychotropic medication. And narrative analysis, again, it allows us to look closer at particular cases and think about the larger, broader theoretical framework while looking at specific cases. And that can help us to provide increased understanding or explanation around decision makings around service use. So these are our preliminary, some of our preliminary work around this, that we also are finding data in these cases around a set of behavioral beliefs, which is one of the constructs in the larger theoretical model I shared around these same aspects. How do I perceive my need for taking medication? What do medications do for me? And in some cases, data around their hope for their future around medication, not all of them. And that does potentially influence, or it may make a difference, it may matter to them with regards to whether or not they use medication, or, interestingly in our work, there are some alternative choice options emerging that young adults will talk about utilizing or engaging that are not, in their perceptions, as useful, or they're more useful than using medication. So I'm going to just share with you a few cases of this narrative analysis that, again, it's preliminary, but it's exciting, and we think there is something to learn from this. So this is a particular young woman who, in our earlier, larger theoretical model that I shared, fell into the young adults who were continuous service users. So that means they used services for a number of different reasons across the transition. And in her interview, there were a number of different statements around her need for medication. I go up and down. I'm not sure why I use medication, and for bipolar. In this case, with regards to what medications do, there were a number of positive behavioral beliefs about the effects of utilizing medication. It calms me, it mellows me, it helps me to focus, it takes the edge off. And she didn't really have much hope for the future with explicit statements in the interview, but there was an implicit hope of wanting to be well for her family. In another case of a young person who was in a category of having gaps in services, particularly in this case, one major gap in services across the transition. That was another group that emerged in the larger study. And in this case, but at the time of the data collection, this young person was in fact utilizing services. And the data elements around need for medication was anger, for sleep, issues sleeping, and bipolar disorder. And what medications do had both positive and negative. In this case, helps me control my anger and makes me lose weight, which was a negative in the context of this case. See, that could be both negative or positive. And the hope was statements such as, I feel like I can do it. I feel like I can do it with medication, and medication as lifesaver. And then lastly, one other case I wanted to share is a young person who fell into the category of a discontinuous service user. In our study, this was someone who at the time of the interview had stopped utilizing services. We had a number of them in our data set. And when talking about why this young man would take medication, he said for mood swings, for bipolar, for irritability. But interestingly, there was a number of negative beliefs around the use of medication. It made me eat, irritability, takes away my personality, statements around that piece, taking away my personality, a number of those statements. And his data around sort of the future was really worry. Worry, he had some sense of worry around his challenges escalating, worry about homelessness, and needing to find a place to go. And this was one of the cases where there was a clear alternative choice option. Not every case there was, but in his case, he was smoking marijuana to manage the mood and emotional challenges. And some of the comments were, interestingly, smoking used to help me in this case. And smoking makes my snapping worse now. So there's a sort of, it's not his current strategy, but that was an alternative strategy that he perceived worked or made sense. So some work that we think can help us glean deeper understanding of questions around service utilization. Again, this is particular to medications. And I think one of the important implications of this kind of data relates to what Mattingly has written about making services or the therapeutic process matter. There's got to be parts of the therapeutic process, whether it be medication, case management, that matter to the client and make sense to the client in their cognitive and affective perceptions. And in the last study, I want to just talk about briefly, I'm going to talk about Just Do You. And Just Do You is an intervention that is developing, certainly, but it builds on a lot of the work that I just talked about. And we have just completed a pilot of Just Do You in 3 cities, and we're going to talk very briefly, I'm going to talk very briefly about that, and then we're going to share a little bit about the preliminary results and talk with some of the folks who've been involved with that. I do want to also say the name of Just Do You came from young adults in Ohio explaining to me the difficult process of getting to a place where they worried less about what other people thought and they just did themselves. Those are my words. They would tell me, you know, not going to worry about others, just do you. I learned later that this is a common phrase. I didn't realize it then. But anyway, it was compelling that there was this sort of process about really being able to do yourself, and that resonated for the young people with mental health challenges. And so what is Just Do You? It's a psychosocial intervention trying to help young people formulate the belief that mental health services can help them. So there are assumptions, some important assumptions here that is a part of my work, which is that for many people getting better includes the use of services. And that's a big assumption. And this intervention, unlike many other engagement interventions, really focuses on cognitive barriers. We know some really important things about the relationship between attention and behavior and the kind of barriers that can get in the way that are really important. Access, finances, transportation, etc. But this intervention is focusing on more the cognitive and affective barriers that have emerged in my previous work and others' previous work. And then also we're trying to build upon specific techniques that young adults have told me they would be willing to engage in dealing with their mood and emotional challenges. And I think the jury's out, but we're learning some things. And so here is sort of a model that is similar to what you saw earlier, but it shows you that this intervention we're about to talk about really focuses on the sessions that young people go to, trying to influence these mediators, which are those cognitive and affective challenges. It doesn't mean we're not interested in the other recognized barriers, but this is where we're developing our manual to try and impact things like mistrust, stigma, hopelessness, fear, and ultimately to shape or formulate the belief that some mental health services can be helpful. So I'm going to tell you briefly about the intervention and what we do to try and do that, and then my doctoral student is going to share some preliminary qualitative data. So it's a group intervention that recognizes the importance for young people of relationship, of connection. Many young people in Ohio told me the value of wanting to be with other people like them. So we at this point are doing Just Do You in a group situation, 8 sessions. And also trying to really represent genuineness, or what kids, I've run across what young adults call really being authentic and being real. Facilitators, young people, and respect some of those qualities. And also the importance of recovery and treatment being a part of recovery, and trying to actually develop worksheets and exercises that we do in Just Do You that help young people connect some of the things they're doing in services with their life goals that are a part of their overall recovery. So that's a sort of value of the group, and also treatment as part of recovery. And then some of the specific barriers. These are direct quotes from the Ohio study with regards to mistrust being a behavioral belief barrier. It was kind of rough at the beginning, talking about services, just because I don't really trust people, or just generally, I have trust issues. So trust is a barrier, and in Just Do You, we try to address this barrier in different ways. We have parts of our sessions that are specific to our recovery role models, sharing parts of their experience specific to moving from a place of mistrust to a place of trust with regards to mental health services and providers. We also use creative arts exercises, both writing, drawing, we have clay, opportunities to really depict and acknowledge past experiences where there has been felt mistrust. And we talk about that because we think in order to move in that process, we need to validate and acknowledge those past experiences that folks have published on impacting further service use. And then really a lot of this you'll see is really based in modeling. Albert Bandura's work has heavily influenced my thinking. And we also try to do good modeling between our co-facilitators who are designed to be a clinician and somebody who's an employee who's working at the agency but is also a service user. And those are very important voices, and we're trying to model trust in that co-facilitation model. Second barrier is the belief that services don't work. This is a powerful belief among young adults, that services are pointless. I get the same thing I'm getting from my provider right out on the street. This is just a couple of examples. So we're trying to use narrative mental health communication, which builds on health communication from the cancer literature, to bring in short vignettes of folks that young people might admire, look up to, and to provide opportunities for them to hear folks talking about how services have helped them in different ways. And then also, we actually do try to build understanding of some of the more common evidence-based approaches. We don't do them. We're not doing the CBT with the clients, but we are in fact going through the principles of CBT to try to relate them to situations in our participants' lives, to bring them to life and try and get them connected to what their providers might be doing if utilizing, for example, CBT. We also do exercises on the relationship between cause and coping strategies. But again, this is in service to trying to build understanding of how services can be helpful. And I'll go through these a little bit quicker. Hopelessness is a powerful emotion among the young adults. The hopelessness part, I guess, the what's the point about getting services. And so again, we use creative arts, the same modalities, but one session is about developing a piece of art that really helps you envision your future. And if you're doing well and feeling better and you're in your recovery, what might that future look like? And then we can talk about that and we can share that. And it's been a pretty powerful experience. And then also the use of our recovery role models, again, having specific parts of the session of sort of moving into a place of more hope. And then lastly, stigma. Right, which is a big barrier on all levels and on all, parts of the developmental spectrum. And I think it's a place I'm just going to put my 2 cents in, where our society has a lot of work to do. We all talk about it, but we have some real challenges about courage and trying to stand up that people with mental illness should not be stigmatized. And so we really try to address this in a couple of sessions. You see a quote up here. I'm not going to read the quote, but again, we use, well, it's cut off, but we use these narrative mental health communication vignettes again, where people who young adults might look up to. The most successful one, not surprisingly, was Mary J. Blige on all 3 sites, talking about the use of services and strategies for doing better. And these are more powerful than potentially some clinicians talking about debunking stigma. And so we utilize those in the session. And then again, the recovery role model, and you'll see some data that young people have shared in these 3 sites, 2 in Ohio, 1 in New York, around their perspectives on the role of the recovery role model. So again, I just want to introduce a second-year PhD student here who's been a really important part of this work, both implementing this intervention and helping with the data collection. She's just going to share some of the qualitative data, preliminary on the intervention, and then we will hear from our other panelists. So thank you for listening, and here is Andrea.
All right, so good evening, everyone. Again, my name is Andrea Cole. I'm a second year doctoral student here at NYU, and I did have a great opportunity to help collect some of this data from both young adults and from the staff participants in the study that I'm going to share with you this evening. So again, we collected qualitative data, and everything that I'll share with you is actually quotes. So I'm going to read through them, but hopefully, it'll be interesting to you. So there will be three overarching themes that we're going to focus on. And the first theme will be from all data that was collected from the young adults specifically, and that's really about the acceptability of the intervention. So, how they experienced the Just Do You group, what parts resonated with them, how did they find the Just Do You group to be impacting them. And then the second set of quotes that I'm going to present will also all be from the young adults that participated in the group, and it's really going to be focused on how they found the inclusion of the recovery role model. And we wanted to know about that because we thought it was a pretty sort of novel part of the intervention, and we wanted to know how that affected them to have somebody in the group that was a role model. And then finally, the last set of quotes that I'm going to present will be from the staff that were also participating in the groups with us. So it'll both be staff that were co-facilitating the groups and staff that were at the agencies that we were having the groups held at, but weren't necessarily facilitating the groups. Okay. And so I should say that the staff quotes will really be about sort of the implementation of the intervention, and did they notice any changes in the agency because of the intervention being held there? Did they notice changes in their own work because of the intervention being held there? And also if they happen to notice any changes in the young adults themselves. So this first set of quotes they're all from the young adults, and it's related to the acceptability of the intervention. And the first participant says, knowing that other people with mental illness have succeeded in different ways and in the future made me think that I can succeed in the future even with mental illness. And the second participant says, attending Just Do You made me feel like I was a part of something. A third participant said, it gave me something to look forward to. And a fourth one said, changed over the course of the group. At the beginning, I was angry, confused, lost, paranoid, and depressed. Now it is some little bit more hope, possibility getting into me. Here's a longer quote, still about acceptability. So every single time I went, I wasn't dragging my feet to get there. I went with a smile on my face. I was happy to go. I enjoyed it. I liked being able to share my poems with other people that understand it. They understood what I wrote about and why I wrote it. I never had that. People actually understood what I wrote. And here's two more quotes. It was a good experience. I have never been in a group like that before. You can put onto paper how you feel. I never used to come here to the agency because I work and I didn't like the group. They didn't talk about things in my life before. Something that kind of helps me too with myself is the art stuff. Like when we had to do a feeling that we wanted to get rid of. I put my mom's death. Instead of always writing my feelings out, I could express my feelings in a different way. So the art helped a lot. So just to sort of highlight some of the things that we think are important in these quotes, you can see that the young adults said that they actually look forward to coming to the group, which can be hard to do. And that they actually came to the agency more often because of the group, or at least one participant reported that. They reported feeling understood, they reported feeling hopeful, and that the use of the creative arts did really resonate with them. So these next set of quotes will be about the response to the inclusion of a recovery role model. So one participant says, the facilitators related to me. The recovery role model is cool, down to earth. Another participant said, they don't put you down, they put you up. And another participant said, I'd say the recovery role model is like my mentor. along with it again from a young adult. It helps because the recovery role model is like a person who, like, recovery role model's been through a lot, and I've been through a lot. So I feel like we have that, like, that similarity there, something in common. And like knowing that there's somebody else out there that's kind of had a life worse than me helps me like want to be there and, you know, try to talk to the recovery role model. The recovery role model is a strong person. Like, I look up to the recovery role model a lot. Like, the recovery role model inspires me a lot. And another longer quote about the recovery role model. Look what the recovery role model went through, and look what the recovery role model is. The recovery role model fought through all that stuff, all that shit that happened to the recovery role model, and the recovery role model made something of it to help other people. And I look up to the recovery role model that way because he or she made something out of it, and I want to be just like that. And I just can't get over how amazing the recovery role model is. Sometimes I think they're not doing this for the money. I think they're doing it just to help us, and that's the feeling they give me. So again, you know, from these quotes you can see that a lot of the participants did have a positive reaction to the inclusion of the recovery role model in the intervention, and that they could relate to the recovery role model. They said they felt supported by the recovery role model, and they felt inspired by the recovery role model. And I think you can see from this quote also that they felt like the recovery role model was genuine, that they were there to actually help them. And so this last set of data is the qualitative data we collected from the staff at the agencies, and we wanted to know about, again, you know, how did the intervention affect the work of the agency. So one staff member said, it impacted daily workflow positively. It didn't create scheduling conflicts. It brought together a cohort of individuals who historically at our agency have been difficult to engage in services. Another staff member said, it did impact things. For example, at intake, when new clients joined who were young adults, it was another service to offer. It was another service being offered for young adults specifically. Another staff member said, I noticed from the beginning to end an overall change in the client's physical demeanor. In the beginning, they were shrunken in, didn't smile, no affect. And at the end, they were laughing, smiling, standing up straight. They grew into their size. Another staff member said the clients had increased caring for one another and formed meaningful relationships with each other. There were meaningful connections made and many experiences shared. A few more quotes from staff. I think that the videos went over really well. I think they got a lot out of seeing that. I think they liked the relatability. I think the fact that they were talking positively about mental health treatment and that it was hopeful. And finally, another staff member said, especially with the Mary J. Blige video, the installation of hope with, you know, the fact that you can still do something. So we did talk a lot about resilience and what made Mary J. Blige resilient. And I think that was a pretty powerful session too. So these quotes really, just to summarize, show that the staff felt that the intervention helped to engage young adults in the services, and that the Just You group at the agency really impacted the agency in a positive way. And some staff members noticed that the clients who participated in the group had a positive reaction also, that they were smiling, they were laughing, and that they were forming important peer relationships. And so that's all the data that I have.
Thank you.
Thank you very much.
Can I ask a question?
Oh yeah, we're not done yet, but you can definitely ask questions when the panel is done speaking. Thank you for your interest. So we're very lucky. One of our 3 sites is right here in New York, and I've invited a couple of folks that were involved in the pilot to also speak to their experiences. And we are extremely lucky that they agreed to come and provide some of those experiences and some of those examples. So first we're going to hear from Sylvia Tidwell, who was a participant in the Just Do You group. And really Sylvia, I think, exemplifies resilience and also was an incredible, really participant researcher who gave us feedback regularly on where we needed to, change things up or keep things as they were. So thank you, Sylvia.
Good evening, everyone. Once again, my name is Sylvia Tidwell. I'm a client in so-called peer advocate and ICF pros. I've been going in 2 years. One thing about me, even though I deal with the mental illness on a daily basis, I don't really care about the mental illness because at the end of the day, I'm doing me. As in, doing me, I do what regular people do. And to tell you the truth, a lot of y'all probably sitting here now with depression, bipolar, schizophrenic, etc. But the thing is, y'all don't take medication like I do. See, the thing is, I take medication on a daily basis, but I do what y'all do. I'm here now, right? I'm sitting here talking, right? At the end of the day, a lot of people talk about me as in stigma. That's a big word for a lot of everybody, stigma. And it kind of hurts, but at the end of the day, I don't give two shits about what people say because I'm me, you know what I'm saying? And I go on about my life, you know what I'm saying? And what I've learned throughout Michelle and David and Redell, all of them, and then Just Do You is you gotta do for yourself because at the end of the day, ain't nobody doing it for you. You know what I'm saying? Ain't nobody paying clothes on my back, ain't nobody feeding me but me. You know what I'm saying? It's a cold world, you know what I'm saying? And it's a small world, you know what I'm saying? And at the end of the day, I just gotta do what I gotta do. I recently applied for my own apartment. I just right now live in a shared apartment. I go through struggles with my roommate, but I can't, go out, with that on my back, you know what I'm saying, as in, me and her clashing, you know what I'm saying, because that's her, I'm me, you know what I'm saying, so, and I really kind of went push ahead and understand what I do, on a regular basis, and I used to be in foster care, and it was kind of hard, because after I aged out, I was homeless, had nowhere to go, but I had to understand that the streets are not my home. You know what I'm saying? What I mean by the streets are not my home, there's a lot of stuff that go on in the streets, and at that time I thought I was big, bad, and tough, wanted to be, just anybody, but you can't. You got to be yourself, and when I bumped my dad in my head, and I hard concrete, because once you bump your head, that's it hurts, I realized that I had an option. I had an option to be on the streets, or I had an option to get myself better and pick myself back up and realize that I do have family. I might not have a big family, but I call ICL my family. I call Just Do You my family. I just want to take this time for thanking everybody for listening to what I have to say, because it takes a lot of courage to come up here and speak from the heart. Because I was going to do paper, but for some reason somebody told me to do paper hard. Once again, I want to thank you, and I really appreciate it to listen to what I have to say.
Thank you. I think that Sylvia knows how to keep it real. So now we're going to hear from Redell, who co-facilitated the group with David and I, and who is in the important role of recovery role model here at our site in New York City.
Hello, good afternoon, everyone. All right, so I'm sitting here listening to these nice, beautiful speeches. I'm hearing about the recovery role model, and how the recovery role model is, has inspired the young adults in the group. I'm like, wait, I am the recovery. So it made me feel good. So before I start, I just want to show you guys the shirt that Dr. Munson and Mr. David Kamnitzer helped us make. So I'm really proud to even have this shirt in my hands. And every participant, every young adult in the Just Do You group will have one of these shirts. And hopefully everybody. Wearing a Just Do You shirt. So, where should I start? So I actually was a client for ICL. I lived in Stepping Stone SRO residence for about 2.5 years. And for those who don't know what an SRO residence is, it's a single room occupancy. Single room occupancy residence, and I lived there for about 2.5 years. And it's staffed by staff 24 hours, 7 days a week around the clock. So I lived there for 2.5 years, and then after that, I made the transition from Stepping Stone residence to a roommate situation with the roommate, and from that step, I moved on to my own apartment, and that experience was a huge, big step for me in my life. Like, for those who have their own house and their own apartment, 2 thumbs up, because that for me is like this. And coming from where I come from, Brooklyn, East Flatbush, Brooklyn, it's a really tough neighborhood, and you can get in trouble really easy. And in my past, that's what I was getting. I'm a little nervous, but I was getting into a lot of trouble in my past and smoking a lot. And a result of that, my mental illness was triggered. I was first hospitalized in the year 1999. But fast forward, someone from Stepping Stone helped me out and brought me to Stepping Stone. I did, overnight there at Stepping Stone, and from that, my life has just changed for the better. So fast forward, I'm a peer advocate for ICL. I work at PROS. For those who don't know what PROS is a day program that is part of ICL, which is Institute of Community Living, and PROS is Personalized Recovery Oriented Services. And my role there is peer advocate. So, there was a point in my life where I never thought that I would even accomplish what I've accomplished. So I went from being a street kid who used to get high, who was involved with a lot of gangs, from getting locked up, from turning my whole life around and leaving all that stuff alone and becoming a peer advocate and having my own place and, dropping out of school, from going back to school and doing good in school and doing really good in math and, the whole transition. I would definitely say that I'm really proud of myself, and I feel extremely privileged and honored and blessed to be just a part of what's going on here, just to me.
And so now we have the distinct pleasure of hearing from David Kamnitzer, who's again a senior vice president at the Institute for Community Living and who has influenced my thinking and this work in a tremendous number of ways. And I think, he's going to speak to you about sort of the collaborative work from his role, his position, and he's also helping us this summer co-facilitate the Just Do You group.
You guys can see I'm a little teary-eyed. I'm a proud NYU graduate. It's been 22 years since I graduated, and I could say for our new grads, 22 years into it, and I'm still very excited and inspired to be in the field. So, and this is, for those NYU students who know, and especially my first years who are in the room, this is my POPs project, you guys. This is an opportunity for me as a provider to look at some emerging trends that are going on in our system and to figure out where the gaps are. And that we have our colleagues from OMH in the room, Brian's here, and Susan in the back, and other folks around the room, and we've all struggled for many years to think about how to take folks who are coming out of foster care or who have spent time in residential treatment programs for many years, and how to continue to provide services for them while meeting their needs. That for so long, if you think about the sort of continuum of care and services in the mental health system, young adults did not have very many options, and that many of them were often thrust into day treatment programs with some very chronic folks who are struggling with schizophrenia and other chronic mental illnesses. And we came to realize that as we learned about new technologies and new evidence-based treatment out there, that there had to be a better methodology, there had to be new interventions, and providers for many years, I remember sitting with Brian on transition age youth task groups at OMH and other providers going back to the early 90s, thinking about the best way to meet these folks. In my early days of running some programs, I was supported by OMH's request to go and speak to the folks who are running the residential treatment programs so as to help them think about how to best transition those folks into the adult system. We worked very hard to try and dispel a lot of the myths and stereotypes about mental illness, and so that despite having schizophrenia or this label that is imposed upon them by this medical model, this DSM-4, or bipolar disorder or major mental illness, the idea is that folks could still achieve significant life goals. We focus specifically in the areas of housing, of employment, of education, and perhaps what's most important is social relationships. And so here at NYU, of course, the clinical school, we start with the foundation of relationship building, right? And so for me, as an administrator, right, in my agency, as a senior vice president, to be able to be given the opportunity to work with my colleague Michelle, to be able to facilitate groups with clients still is a privilege that I really feel, to be able to build those relationships. And I think that that's something that, a message that I want to put out to you, that just do you, the model here, certainly Redell as the recovery role model is a significant face of hope for these folks. But no doubt, as we were doing this group, Michelle and I constantly talked about what role we were as good objects to these folks in the group. And there was constant processing amongst ourselves about what it meant for the young folks in this group with regard to their own transitions and what was being played out. This is a very interesting model. It's, some would say, it's part psychoeducation, it's part group therapy. There was not a whole lot out there in terms of the curricula. There's some stuff on psych rehab, there's the symptom management modules, and there's the medication management models, and there's these modules on safe sex and how to use a condom and things like that, but there's nothing really that ties in issues that integrate all the lessons that Just Do You does. Again, an opportunity to partner with NYU on this project, to get the support from our significant stakeholders, OMH primarily, and their investment in young adults is just key. You also, it's really very important too that as you do this work, you have to always be thinking of the regulatory framework that you are under. And so we very clearly, work through, does this fit into our regulatory structure? Is it meeting a medical necessity, right? And so working through those difficult issues was part of my due diligence. Certainly I would give a special shout out to ICL CEO and founder who's in the room, Dr. Peter Campanelli, who's here. I didn't know he was coming. just having him here is very special for me to see, and getting, again, we talk about stakeholder support, his support and his buy-in to this emerging population obviously is very important. And then, you know, the real proof is just the clients and creating an environment where Sylvia talks about her housing and her outcomes, right? We're in an outcome-oriented world. The days of folks staying in your programs for 2 and 3 years is long gone, right? We're in a process of you know, a whole new redesign of our healthcare system. So we're constantly talking about new methodologies that will help support outcomes while also keeping people connected, healthy, and well. And I think that's what Just Do You does. And yeah, just what was so, you know, beautiful about this partnership is that it was very much fit into our mission, and the mission of hope and resiliency and recovery. So, thanks.
And just one more piece, last but not least, is my colleague Nadia Jenefsky, who I wrote it here, is the clinical director of New York Creative Arts Therapists. And really, again, I've been working with Nadia for over a decade, almost 15 years, really about trying to figure out ways to use visual arts, creative arts, to engage some of this material alongside social work. And I wanted to provide an opportunity for her to speak because we do use some non-traditional modalities in this intervention very strategically and as part of the intervention. And then we'll have a good amount of time for comments and questions. So, Nadia.
I'm really very excited to be here, and I'm so grateful for Michelle to be, you know, have welcomed me into this program. And I was thinking about how long we've known each other. And one of the things I wanted to speak to was actually the stigma piece, which we were talking about earlier. And Michelle and I met working in inpatient psych unit and on an adolescent unit. And this memory came to me as I was walking over that really speaks to the stigma of mental health. So this was 15 years ago, but it probably hasn't changed so much. And what I remembered was that the adolescents on the inpatient unit that we worked on together, when we had our group meetings, they would talk about, you know, what it's like to be in the hospital and who's missing them at home and all these things. And I remember specifically that many of the patients on the inpatient unit would tell their family and friends who didn't know that they were hospitalized, that they were incarcerated, because they would prefer to let people think that they were in prison instead of being in a hospital, in a psychiatric hospital. And I just think that that's really poignant. And it speaks to the vulnerability that people who experience mental illness have to carry with them, that they would rather be seen as, perpetrators of crimes than as these vulnerable beings who suffer from mental illness. So to speak to that particular stigma, I think the creative arts offers a really good opportunity to introduce dignity into the experience of being a mental health patient or just somebody with mental health issues. Because when you're working in the creative arts, what you can offer participants is another type of identity. So there's a lot of issues that people have around being labeled with mental illness. And by engaging them in a creative modality or by allowing them to use creative expression as a part of their treatment, we're really engaging them in a different part of their identity. So I'm not necessarily always a therapist, but I'm also an artist, and therefore I'm more of a peer than of, it changes the hierarchy of the interaction. And it also provides the artists, the patients who are engaging in the art therapy to see themselves in a different way, which is not that I'm this person who's flawed and vulnerable and scared, but I'm somebody who has a purpose and who has value, and and I can engage in things that are productive through the art. So that's kind of my approach when I think about what introducing creative arts into treatment models represents, this idea that it just restores dignity in a way that I think very few other interventions can. So that being said, I wanted to talk, Michelle asked me to talk a little bit about a trauma-based approach, and I'll get to why specifically. So we were talking about stigma and trust. And so just for the purpose of me talking tonight, I wanted to give you a working definition of trauma as it fits into this context. So just what I came up with is trauma would be a compromised sense of personal or physical safety, integrity, or agency. So I'll say that again. A compromised sense of personal or physical safety, integrity, or agency. So now, we use the word trauma a lot, and I work from a trauma-based approach, so my bias is kind of that trauma exists in all aspects of life. So just the more obvious definitions would be, physical abuse, mental and emotional abuse, sexual abuse, but also social or familial neglect. Poverty is definitely a big traumatic factor in a lot of people's lives because, again, it compromises their sense of integrity or agency. Discrimination, including discrimination against people with mental illnesses, chaos or war, and then, more specifically to this conversation, mental illness, I'm defining it as a traumatic experience because, being a person who decompensates or finds themselves not able to function as a normal, as an average person is definitely a traumatizing experience. And in addition, having a mental illness will make you more vulnerable to all the other kinds of traumatic experiences that I just listed. So just to talk a little bit about art therapy and how it would apply and, from a trauma-based model. So I think most people are probably familiar with the expressive components of art therapy or the creative arts, which is the idea that people can use art to show or share or just kind of express, since it's expressive, their experiences in ways that don't necessarily involve words. But what I'd like to talk about more specifically is how it also can serve different functions. So the first thing would be to consider the idea that when you have a traumatic experience, as we know now from research and just our training, a lot of traumatic experiences are stored kind of in the body and they're not fully processed. So you have this piece of your identity and of your life experiences that is kind of undigested. And so the first thing that creative arts therapies can do is allow a physical outlet for this material to start to move out of the body. And I wanted to bring artwork, but I don't have any because it's very difficult to get artwork releases for me to show the artwork. So I just thought we would use examples that we all know. So for this particular example, think Jackson Pollock, right? So this is the idea that you can just use art in a very kinesthetic and physical way to just kind of release pent-up energy or stress or any kind of impulse that was in your body that you had to hold in because you were in a situation where you couldn't, and there's this very kind of cathartic experience that goes with that. So that would be kind of the first tier of the creative arts intervention. And then the next piece of it would be more cognitive. So here we're talking more about expression in the sense that you're putting something into a symbol so that you can start to create meaning around something that's happened to you. So think, the one we all know would be the scream, right? So the scream is this very visceral painting and it's this very intense face, and I think everybody who looks at it knows exactly what the painter was trying to express. But when you look at it a little bit more closely, you understand that there's a lot of cognitive kind of processing that has to go into creating this kind of an image. It's not just like a Jackson Pollock, although he probably thought a lot about what he did too, but it's been given some form, so it's moving from just kind of cathartic expression into really giving it form, giving it a symbol, and giving it meaning, which is, when you're trying to move a traumatic experience out of your body and into a place where it's more integrated with your life experience, that's kind of how you want to go. And hopefully at some point, it can also lead into being able to talk about things that are just really difficult to talk about. And then the last kind of art, what is it? Sorry. My lips so dry. We'll do a Marco Rubio here. So the last one would be, this is what I need to be doing right now, the self-regulatory component of art making, right? Which is the idea that in trauma there's a dysregulation that happens, and that art can actually help restore self-regulation. So that means that art is not always used necessarily to go into the trauma or explain the trauma or delve into it and explore it and share it, although that can be a part of it too. But art can be used for soothing and for containment of material and for creating a sense of safety, which is kind of something that's been taken away from people when they've had traumatic experiences. So in terms of, what our collective canons are, you could think of Monet's water lilies. So that would be an example of art that is, that takes you to your happy place, or that brings you soothing and calm and tranquility. And that can be a very, very big component of a creative arts treatment modality, where you're not necessarily going into difficult material, but you're actually giving people experiences that are pleasurable and that are satisfying and that restore normalcy and just help self-regulate. And I think that, when we're talking about this particular project, I think incorporating the creative arts was part of the idea behind it for Michelle was to include a sense of pleasure and enjoyment in participating in mental health treatment, which kind of goes against what we've come to believe about mental health, is that you go in and you do the work and you have to talk about painful stuff and it's horrible and then this person is looking at you and you don't know if you can trust them. There's a lot of obstacles to overcome, and so just in terms of the buy-in of really getting people to engage in something and believe in it, which is a big part of what this project is about, being able to give them a modality or just give them a tool that they can use to start working on stuff at whatever level, whether it's Jackson Pollock or whether it's the Scream or whether it's the other stuff, but that they can, people can immediately start to engage in a way that feels good. And I think that's just a big part of it too.
Thank you.
Thank you. Thank you so much for listening. I want to get immediately to questions. Is Liliana still here, or you want to start and then we'll go over here for anyone or any topic? Liliana?
No, I'm
Okay.
good.
Yeah, I wanted to ask the two young adults what they thought was the worst thing case managers did for you, the worst thing they hated, and the one thing that you really loved that really helped you, move on. So it was both of you. Just watch
The worst part case manager ever done was talk about the same thing over and over. Like when you go on a session, you're not supposed to talk about the same thing over and over. And the second thing that a case manager ever done was in a positive way was help me understand that I'm not alone in my recovery. And it's okay to talk.
I think the worst thing for any case manager is, I guess, like negligence in a way, negligence meaning not to listen. If any participant, including me, is expressing that, hey, you know what, I'm at this apartment and, I'm living with other people that have mental illness, and dude was on my fire escape. And, I'm expressing this and I need you to take this serious, because dude was on the fire escape. And on the flip side of the coin, listen. So the worst thing to do is not to listen. It's like, okay, everything's formative, do paperwork, all right, I'm out of here. We good? All right, peace. All right, later. But I think the best thing a case manager can do, not only for me, but any participant, is to actually listen and to seriously listen and take it. Say, well, you know what, okay, let's take some steps at A, B, C, X, Y, Z to solve this situation. Whatever the situation.
Other questions or comments?
Yeah.
First of all, I want to thank all of you. I have learned a lot and it's been very, very informative. I have a question. My concern is about substance use in young people. And from your experience and your work, any suggestions that can be helpful to us? What do you think we need to know as professionals in terms of what has helped you or anything that?
As for myself, I have never in my life used substance, no alcohol use. And the way I cope with daily living, and even if I have struggles, my best coping skill is to either draw, write, or listen to music.
I think one thing that you probably shy away from is religion, and maybe a lot of things that have to do with health and what smoking does to the lungs and what does it do to the body as far as the effects that smoking has and the negative effects that smoking has on the body. I think I used to smoke a lot. I used to smoke a whole lot. I used to smoke a lot of weed, and that's what triggered my symptom. If I was to take one pull off or a marijuana blunt, you'll see a totally different person. The monster come out. Dr. Jeff, which one is the bad one? Mr. High. So you see Mr. High. That's if I would smoke. And one thing that really helped me was my religion. It was my belief in my God. And I think that we shy away from that. I don't know if I'm too wrong, but I think that we don't talk about that. And I think that would help us as far as mental health. Why not talk about what you believe in? I think that.
If I could say, just sort of to build on both Sylvia and Redell's points, I think we need to be very serious about creating new innovative strategies that are attractive to young people and that will bring young people around. And if that means poetry and that means talking about their faith, then let's listen to that.
Can I ask, along with that, thinking of things that attracts us in our book, and one of the things that we've talked about with the staff is what type of what makes you feel good about another person? What makes one person trustworthy and one person not trustworthy? And what characteristics are different? Because I think that would be helpful for folks to know. So why do you like someone and why don't you like someone?
That would be a personal.
I'm talking to you two. So when the service provider,
just regular.
So what makes a service provider accessible, and why do you like them versus the ones you don't like? What's different?
Oh, I can relate. I had a case manager. She's no longer in ICL. Her name was Dana Flores. But it's okay. Me and her had a close bond, as in me and her has a close bond, which I mean, whatever I had problem, whatever I had issues, she would be there like a Speedy Gonzalez kind of type of person. Now it's to the point where I have another case manager. Me and him don't get so well too long, we don't get along, and it's to the point where I have to get that to know him as I got to know the first one. Everybody's not going to be the same, but it's to the point where I have to understand that they're here to help me. They're not here to harm me or talk about me or anything, because at first I was like, fuck this, he's here to talk about me or negative shit, you know, but I have to realize that everybody is not the same.
So it'd be helpful to say, since I know Dana and I may know who you're talking about, is that one person. What I'm saying to you, my darling, is this, is that it's the warmth and the accessibility, because one of the things I think that you liked about Dana, if I recall, is that she was nice, she was warm, she smiled, she was genuine. Does that sound like it rings a bell?
Right, she was understandable, which is the point each time you gotta sit there for hours just for her to understand.
A few more questions.
Switch, back in the corner here, and for anyone on the panel, thank you.
Okay, my name's Elizabeth, second year student here. I really enjoyed the talk about so it's inspiring. It's great to hear personal stories too. I think partly I'm coming from a really engaging meeting on sort of systemic racial oppression from my field placement, and I just noticed like we didn't mention race at all in terms of how that contributes to trauma in our society. I wonder why not? Because we talk about trauma, we talk about poverty, but we didn't name that.
Are you asking my opinion, or are we going to open that up? I mean,
just
certainly I think racial discrimination can definitely be a trauma for many folks.
I guess I wonder how it's addressed in the program, too.
How it's addressed in the program. Well, specifically, the ways that are coming to my mind, and you guys can feel free to chip in, is that we have one session that talks about oppression and discrimination, and we talk about different types. It includes living with a mental illness, which is the primary focus of our program, and what kind of an oppression experience that is, but we also talk about race, class, gender, and oppression more broadly. And the other way that race plays a role is that we're trying to adapt the model or tailor the model to the composition of the community and the participants that come. So trying to recruit facilitators who are of a similar background, use vignettes and podcasts and experiences that might be more relatable. I don't know if that responds to your question.
Yeah, that's the lines a little more.
Any others want to comment on that?
No, just that I think, you know, I agree with you that those issues are always there, and that it's something that you know we pay attention to in every single group, and it's part of. I can tell you that the group that we facilitated, which had 12 participants, with I think the average norm of about 8. So we had high retention rates. Was very mixed in terms of race, gender, sexual orientation, and so the members, you know, brought it out sort of organically. It wasn't for a prescribed lesson plan or anything, and that's just how it evolved.
Any others? Comments, questions? Yes, in the back.
Well, as the Office of Mental Health, one of the Office of Mental Health representatives here, I just wanted to echo again, I think something that's so important is that after years, and I'll tell you, many years of being in this field and being a mental health administrator, it's been a long battle to fight for services that are specifically tailored to the needs of young adults. And it's really gratifying and very important that you've started to develop this model. And there's a lot of research, or some research now, taking a look at what it is that young adults need. Because for a long time, when you were 18, you were an adult and you had the same needs as somebody who was 55 in the world of mental health administration. So this is really a great step forward.
I appreciate that. Thank you so much for that comment.
And Michelle, unbelievably, it is time for us to end, but I hope that this audience can do a couple things. So first of all, this has been such an impressive panel, because just because I was kind of looking through the door didn't mean that I didn't hear every word. And so I really, though, appreciate Michelle and all of your collaborators, your perspectives, and your ability to work together from very different vantage points. I think it is so admirable. So before we all clap, I just want you also to know that McSilver is having a small reception, so if you'd like to interact with any of our speakers tonight, that will be on the 4th floor in Hopper Studios. Please join us for a seltzer water, a small glass of wine, and feel very free. If you didn't get your questions answered, you can pick everybody's brain here. So let's take